You're listening to Case by Case, the podcast where medicine meets real-world practice, one clinical case at a time. Brought to you by a continuing education company, this series brings you front-row access to compelling case studies recorded live at top-tier CME conferences across the country. Each episode, we dive into a single, real-life medical case presented and discussed by leading experts in the field. It's medical education elevated, engaging, and deeply relevant to today's practice. This is Case by Case. Let's begin.
All right, I'm going to pass it on to Dr. Desai.
Thank you. All right, so let's dive into the next case here. 64-year-old man with history of coronary disease. So here's kind of the more detailed presentation. So 64, history of CAD, had a PCI 3 years ago, hypertension, hyperlipidemia, type 2 diabetes, presents for routine follow-up. Feeling well, has been adhering to his medications and lifestyle interventions. He has a recent echo that was done. EF was 60%, no significant valvular disease, and normal diastolic function. Physical exam is there. His blood pressure is well controlled. He's in sinus rhythm. Heart rate is in the 70s. His BMI is elevated at 34. You do auscultation. There's a 2/6 early peaking murmur. Otherwise, pretty unremarkable exam. You look at his medication list. He's on aspirin. He's on atorvastatin and ezetimibe. And so hopefully his LDL is well controlled on that. He's on lisinopril 20 milligrams and metformin 1 gram twice daily. There's some other labs available at the time of the visit. Creatinine is 1.0, which gives you an EGFR of about 75. The A1C was 6.8. LDL is 55, HDL 62, total of 148 with trigs of 126. And the EKG is there with maybe some borderline LVH. So our first question here is, which of the following tests would you best recommend be performed at this time to help characterize this patient's risk for recurrent events and help guide clinical decision-making? A, going to get a coronary artery calcium score for risk stratification. B, you want to check a lipoprotein little a. C, you want to check a UACR, a urine albumin-to-creatinine ratio. D, you want to get a genetic analysis with whole genome sequencing. What do you guys think? All right, so 90% say UACR. I certainly agree with them. You know, I think I'd like to get, maybe Jan's comment
Hit it again.
On this as well, and maybe Marie's as well. So when you think about calcium scoring, right, we typically think about that for our primary prevention patients. If you're kind of in a gray zone, you're not sure what to do. That's really where the guidelines have advocated for calcium scoring. So in a patient like this, right, that's in their mid-60s, they have documented atherosclerotic cardiovascular disease, they've had a PCI, 3 years ago, I would say fairly limited utility for getting a calcium score, right? They've already been on a high-dose statin, and so chances are that calcium score that you get is only going to kind of muddle the picture and lead to probably some more confusion and kind of muddle things. So I certainly agree with UACR. We showed this, in our CKM talk. I think, despite how easy this test is to get and to do, and how powerful and prognostic it is in terms of risk, it is still underdone. And that's true in internal medicine and family practice and primary care. It's true in specialty practices, because we're like, oh, that's like someone else will do that. Oh, like that person's going to see, this provider, and so they'll take care of it. Again, I was sort of sharing with you in the midst of our talk. We're all in it together, for the patients and the communities that we serve, and so everyone has a role to play in kind of helping that patient and that family. And so, UACR is really important for everyone to kind of step forward and to step up. And I would just re-highlight again on the right that if you're just waiting for the EGFR to drop, chances are you could have found that CKD 3 years earlier, 5 years earlier, 7 years earlier, and instituted cardiorenal protective therapies that would have preserved kidney function and likely could have reduced, adverse cardiovascular events. And so maybe, I don't know, Jan, if you guys want to make a comment about UACR or what, whether you've done it or not done it, or what's kind of happening for you guys.
It's endocrinology. It's a real quality marker, like the retinal exam. But just as you said, we only get it done in 60% of our patients, which is
look at that,
unbelievable. And the reason I know this, it's up to date. We're trying to recruit for a study.
Oh, look at that.
With folks with albuminuria above. We're looking for people above 90 for various reasons.
Okay.
And we're looking at our patient population, like only 60% of people who need this test are not having it done.
Look at that.
There's a couple of reasons. I think we used to say a screening test that's positive, you don't follow it anymore. So it's positive is over 30 in diabetes land, right? Then your land too.
Yeah.
And you don't follow it anymore. If say it's like in the 40s, you say, oh, okay, we'll put you on an ACE inhibitor and you'll be fine. But now we know it's progressive.
Yeah.
And actually the progression is what we should worry about.
Yeah.
So a big fan of the UACR. I was going to ask you about the calcium score. I have patients who are on max, statin therapy. Their LDL is in the 70s, and they say they have really high risk. And they ask, should I have a lower LDL?
Yeah.
And we say maybe you should. You don't have atherosclerosis, but you're at high risk. We're maxed on your statin, and they say, well, is there another test we can do to just push me to add another agent to my therapy to get me below 70? In those people who don't have heart disease per se, but are at high risk. Do you ever get the score?
Yeah, so it's a great question. So I would say for that person, and we have a fair number of those patients in our practice, and actually Jan and I were talking about a very similar case to what you just described just yesterday in the morning. You might say maybe get a coronary CTA and see what's happening in the coronaries, not a calcium score. Mm-hmm. But the broader point, I think, to your very good question is, we know, and this is a little bit off topic, and I know you're going to have some sessions with Christy Ballantyne, who's really terrific and kind of a real expert on lipids, and so I think you'll really enjoy that. But we know the relationship between LDL and vascular disease is really about cumulative exposure. It's really akin to pack years of smoking is to lung cancer. And so my approach and what I say to our patients is, geez, why leave your arteries bathing in an LDL cholesterol of 120 for the first 60 years of your life?
Right. Wait
till you have an event, and then everyone runs around and tries to get your LDL to 25, which is great. I mean, that's the right thing to do for that person. If they've had an event, then that's what we want to do. But another approach, right, a better approach, a more prevention-oriented approach would be, let's just try and get people's LDLs to the 50, 60, 70 range and not have that event ever happen, or maybe it'll happen at age 80 or 85, rather than happening at age 60. And so I'm a real advocate, I think, for lower is better, and certainly for longer. I don't know, Jan, you want to make a comment?
First, I need to know what statin they're on and what dose. I wouldn't do any more testing. I think I would add ezetimibe. I get them on a high-potency statin, get them on ezetimibe, which is very inexpensive, almost no side effects, get their LDL down to closer to 55.
Yeah.
The coronary calcium score is just going to lead you down a slippery slope on a statin.
Yeah.
It's hard calcification. The number's going to be high. It's going to breed more tests. And I basically have on my wall for all my students, our technological advances have superseded our knowledge of knowing when to use them. Stop the testing. Just make a decision.
Yeah.
I mean, come on.
That too.
Yeah. There are so many studies now in people with underlying ASCVD that a high-potency statin and ezetimibe is better than anything short of a PCSK9 inhibitor.
Yeah, that's right.
I mean, what are we waiting for here?
Yeah.
Yeah,
get the LDL down. All right, this we saw. I'm going to move.
Let me just make a real quick.
Please.
A 28-year-old female comes into your office with new onset lower extremity edema. You get a GFR, it's 110. Her other labs look good. Unfortunately, you didn't get a urinary albumin-creatinine. She's got IgA nephropathy, and she's spilling 1.5 grams of protein in her urine.
Yep.
That's why you need both. Just one small example.
Yeah, that's right. We talked about this in the interest of time. We're just going to go forward here. Again, why you need both. It really matters. And look at all the professional societies that are advocating for this. Right? Everybody has recognized the importance of eGFR and UACR testing to identify CKD. Everybody. And so we are all in it.
Real quickly, in the hypertension guidelines, the last one we had was 2017. We did say estimated GFR, and as an alternate test, we said urinary albumin-creatinine ratio. That was a mistake, but we said it because insurance companies in a non-diabetic were not paying for it.
Yeah.
There's going to be a new guideline this year in about 3 months, and I think it's going to say both, like in a diabetic, like in all patients, you need both complements.
That's great.
Couple quick points. It is a spurious test. This is not the most incredibly stable test. So the point I want to make is somebody who has hyperglycemia in your office, you suspect it or you know it, it's not the best time to get a UACR. You'll see a transient elevation in proteinuria. Women around menstruation for sure, because the heme measures as protein by the assay for reasons that aren't totally clear to me, because it is an albumin measurement. But you do see that. And so be careful. The other thing is, if you have an elevation and it's higher than you think, just repeat it. There may have been, what are the other factors? I think recent aggressive exercise, you can have a false elevation. So it's known to be spurious. You might need to repeat it to reassure or to make the diagnosis, and the guidelines all say that.
Yeah, that's right.
Get to.
Good point.
One other point, in your last question, 2%, probably one person, said B in the question.
The LP-little-a.
An LP-little-a, because that person heard that loud systolic ejection murmur and was thinking of aortic stenosis. And yes, LP-little-a is now recommended by the National Lipid Association as a screening test in high-risk people. It's a high-risk person. So more on that on Sunday, but that person should be recognized. It's not the best answer. C was the best answer. But you could fight it, tell the professor.
Right. That's right. No, when Christy comes, you guys will be
talk about
well positioned for that. Yeah, that's right. All right, so to continue on with our case, UACR is done and comes back at 10. So that's good news. Based on these results, which of the following would you recommend to this patient interested in reducing his risk of having another adverse cardiovascular event? A, tight glycemic control, A1C less than 7. Going to begin semaglutide every week, start finerenone, begin empagliflozin, or E, you're going to do both B and D, 2 and 4. What do you guys think? So this is a good split, and I will say, I think as Jan and I were talking about this question, we had some of our own back and forth, and almost intentionally liked this split. So I think let's sort of go through some of the slides, then we'll come back to this. I think one of the things that we sort of talked about, again, patient with diabetes and atherosclerotic cardiovascular disease. That's where this patient kind of fits. And their BMI was 34, right? So it's that obese ASCVD diabetes, kind of phenotype. What are you going to choose for them? And I think we talked about this a fair bit. It's no longer dealer's choice, right? For kind of what you want to do. And if you look at the practice guidelines, they're really kind of pushing you, right, to a GLP-1 RA and or an SGLT2 inhibitor. Combination therapy, fine. I think why I would have said semaglutide is just because of where the BMI is and ASCVD and diabetes. But again, I think we intentionally wanted there to be some discussion and some back and forth in this one. So with that, I'll have both Jan and Marie, I think, make a comment about what they think.
I'll comment. The 2 points I wanted to make. One is that if this patient did have an albumin, a UACR of 100 or 150, I think dual therapy early is the right move, right?
Fully agree.
And that's not what the question was, but I just want to make that point. The ESC, though, I think the ESC is now saying for this particular patient still to do combination therapy. I think they are. But I agree. I completely agree. The other point I want to make, if you go back, Nahal, to the this one, the mortality, I just want to point out, because I discussed this with one of the audience members who astutely brought up that GLP-1 agonist therapy can sometimes bring you to an A1C in what we call normal glucose regulation, which is an A1C below 5.7. It can bring you there. You know, you could have an A1C of 8. It brings you there because of all the things that it does, right? Yeah. This is not what we're talking about when we're looking at the ACCORD study and mortality. The mortality increase in the ACCORD study, which was aggressively trying to use all the available agents to get glucose lower, below 6.5 A1C. Those who actually had a higher mortality were in the aggressive treatment arm and were more likely to be on insulin. And even though hypoglycemia wasn't clearly the cause, there was some suspicion there. It's just the way the study was analyzed, it was hard to totally tell. But it was also, interestingly, the people who had the mortality excess weren't able to get to the A1C below 6.5. I don't know if you ever heard that before.
No.
The ACCORD. It's interesting. So it's the pummeling the glucose down with all the drugs is not good for you. Yeah. But if you get there with the GLP-1, it's great. Do not withdraw therapy. If you achieve normal glucose regulation, do not stop the GLP-1.
That's right.
That's bad for the heart.
No, that's great.
To this day, I had 142 patients in the ACCORD trial.
Oh, yeah, that's right.
Look at that.
And to this day, we really don't know why that group did die sooner. But we think that it was aggressive over-insulinization and getting them to an A1C too quickly. Unsure. Bottom line on this patient is you go to a clinical trial. So is there a clinical trial that this patient fits of why I would do what I would do? He's a select patient. Select patient. So semaglutide was used in that trial. That's why you would do that. The other thing is, if I'm not mistaken, in all diabetics, it's now recommended that a BNP or an N-terminal-proBNP be ordered as a baseline test. So you might have another reason, based on if he has subclinical heart failure, to utilize that, and/or an SGLT2 inhibitor if he has now a BNP or an N-terminal elevated. His ejection fraction, you said, was 60%.
Right.
I mean, you don't know that he doesn't have clinical heart failure. So now you're going to use both an SGLT2 and
that's a great
and the GLP-1 receptor agonist, and that would have made B and D correct.
That's right.
Yeah.
Exactly.
So it's
it's great. I think you guys
nothing's etched in stone.
Guys are right.
You have to be able to defend to the people that are going to deny you from getting these drugs exactly why you're doing it.
You do.
That's right.
You do.
Look at the SELECT trial. Deny me that.
Yeah.
Right.
That's right.
And the BNP guide, I didn't go into it because I knew, we were going to talk about it, which we covered so beautifully. No. I always learn from my cardiology colleague. But the ADA does recommend BNP for anyone with high risk for ASCVD or who has ASCVD. And we're doing it, or we're getting a lot of echoes all of a sudden. Are my nurse practitioner team members, or our nurse practitioner team members and PA members comfortable with that? And some of our physicians, no, not really. I think that's the challenge. We need a little help. I think I feel more comfortable because I talk to my cardiology colleagues all the time. But, not all of us are going to feel comfortable with going down the road of diagnosing heart failure with the current evidence. And maybe we should just stop that and realize that the BNP is like measuring the blood pressure.
Yeah, that's right.
Oh, I think that people in this audience are comfortable getting
All right.
Yeah.
BNP and an N-terminal BNP if necessary.
Good.
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 Thanks for watching. If you found this discussion valuable, be sure to like, subscribe, and hit the bell so you never miss a new episode. To explore upcoming CME conferences and earn credits while staying at the forefront of medicine, visit cmemeeting.org. Until next time, keep learning, case by case.